and then we can get started. Welcome everyone to today's presentation, Fall Vaccines for Marginalized Communities, Building Clarity, Guidance, and Trust. Many of you know me. My name is Martha Alvarado. I am the Manager of Online Education for Migrant Clinicians Network. And before we get started, just a few housekeeping items during the session. If you have questions, please stick them in the chat and we will address them either at the end, or if you prefer, Dr. Medeiros, we can interrupt you. Let me see. At the end of the presentation later on today, you're going to receive a follow-up email from myself. It's going to include a link to the recording, a link to the post-session evaluation, and a PDF of the PowerPoint presentation. And in that PDF, there's going to be several resources that are linked. The links are live and they will take you to the desired website. Let's go ahead and go to the next one. Just really quickly, this session we have applied for continuing CME credit, and the application has been filed with the American Academy of Family Physicians, and determination of credit is pending. Next one, please. And just to be in compliance with the American Academy of Family Physicians, I'm just going to read this statement out loud. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or just distributing healthcare products used by or on patients. Let's go ahead and go to the next one, please. And I want to introduce to you our presenter for today, Dr. Laszlo Medeiros. As Chief Medical Officer for Migrant Clinicians Network, Dr. Medeiros is responsible for the oversight of MCN clinical activities. He also serves as subject matter expert for various health topics, including emerging issues, agricultural worker health, and tuberculosis. That's a very quick introduction, but with that, I'm going to go ahead and give it away to you, Dr. Medeiros. Thank you so much for being here.
Great. Thanks, Martha. Thank you, everybody, and welcome for being here. I'm going to try to update you on the landscape in the United States of vaccinations for this fall and winter season of 2025 going on to 26. And first of all, I want to say I am a board-certified family physician and member of the AAFP. And I've been a family physician for about 30 years in South Central Pennsylvania. I worked with migrant programs and our migrant workers in the Gettysburg area of Pennsylvania. And I've also worked part-time as a hospital doctor, and so I have the advantage of seeing, who gets sick enough to be hospitalized and what viruses they may be having. So I get a view of that inside the hospital as well as the outpatient clinic. So today, our learning objectives are that by the end of this webinar, participants will be able to describe current clinical recommendations for influenza, respiratory syncytial virus, which is RSV, both adult, maternal, and then also infant RSV monoclonal prophylaxis, and then COVID-19 vaccination. You also should be able to be explaining the impact of the evolving FDA, CDC, state, and pharmacy policies on vaccine access and delivery. These are changing state by state. I won't be able to get them quite as specific as I'd like because there are very many different variations on that, but we'll get into that. We also will be able to identify common access barriers faced by the underserved populations, including agricultural workers, mobile people, and under or uninsured patients, which are a lot of our clientele at Migrant Clinicians Network. Next slide. So we're back to the respiratory season in the Northern Hemisphere, and respiratory infections are caused by bacteria, viruses, fungi, and parasites. Sometimes there's combinations. A virus can get you weak enough that bacteria will jump on board afterwards. So some of our cases are more complicated, which involve more than one. But in general, it's often started by one of these respiratory infection parasites, fungi, viruses, or bacteria. Many spread person to person via respiratory contact. That is, somebody sneezes into the air and you breathe it in and it goes into your lungs. Vaccines can prevent or lessen disease severity, reducing hospitalizations and death. And again, I can attest to that being a hospital doctor that that the vaccinated patients that I serve uh, very rarely get sick enough that they need hospitalization, and if they do, then they will survive and get home much better than the people who have not been vaccinated. That's still true today. Healthcare workers and those caring for high risk individuals are especially affected. So these diseases impact the airways and the lungs. Some circulate year round, others peak in the fall and winter in the northern hemisphere. Common outcomes include pneumonia, bronchitis, sinusitis, and other severe complications. Next slide. People at higher risk for respiratory infections and complications include seniors, and I myself am getting to that point now. So usually this is in the mid 60s, and at this point you're considered high risk, and so the recommendations are often to get your vaccinations up to date around age of 65. Children, very young, and then people with chronic health conditions such as diabetes, heart conditions, respiratory conditions such as asthma or chronic obstructive pulmonary disease, COPD, pulmonary fibrosis, people with cancer, and some who are taking cancer therapies, making their system somewhat immunocompromised. Then there are neurological conditions, kidney disorders, liver disorders, metabolic disorders. Again, we get to the immunocompromised people in general, people who've had transplants, for example, and need immunocompromising medications to keep their organs that they received in transplant. Other people also high risk include healthcare workers, essential workers, farm workers, tobacco smokers, pregnant people, people with disabilities, people who are overweight and often morbidly obese, and people living in nursing homes and long-term care facilities. I would also include some of our farm workers who live in close quarters with each other in trailers, for example. That also includes essential workers and sometimes others who are in close contact with each other. Next slide. So we're going to talk about influenza first. So clinical recommendations for influenza. The current vaccine covers three seasonal strains. The effectiveness is that it reduces risk of needing a doctor visit by about 30 to 60%, depending on the year. It reduces hospitalization and intensive care for children by 74%. It reduces death risk by 50% for high-risk children, and for other children, risk of death drops by two-thirds. So who should get the influenza vaccine? Everyone 6 months of age or older. Special formulations are also for older adults. Sometimes there's a split dosing that's recommended. When? Best time is October, which is right now. And anybody under 9 years getting their first dose needs two shots. Again, the split dosing for the younger under 9. Next slide. Clinical recommendations for RSV. For the older adults, 3 vaccines are available. GlaxoSmithKline, Pfizer, which is protein-based, Moderna, which is mRNA-based. The GSK Pfizer real-world safety is been tested and has a great track record. It's longer lasting than Moderna, and there is a small Guillain-Barré risk to that. Moderna, as an mRNA vaccine, has no evidence of increased risk of developing Guillain-Barré. One lifetime dose, updated on October 9th, for adults is sufficient. Who should get this? Anybody 75 years or older should be vaccinated with RSV, and 50 to 74 may benefit, especially those with risk factors and working with high-risk populations. So I myself, as a physician working in the hospital, even though I'm not quite 75 yet, but I'm in the range where I would benefit from this vaccine. Now is the best time. Again, October is a good time to get vaccinated. Next slide. Recommendations of RSV in pregnancy. The Pfizer vaccine is recommended. It passes not only to your own body, but the antibodies pass to the newborns, and it's about 7 to 85% effective. Pregnant patients between 32 and 36 weeks benefit the most. And the ideal time for this is September to January, again, the winter season in the Northern Hemisphere, and be co-administered with other pregnancy vaccines. So the American College of Obstetrics and Gynecology, ACOG, recommend this vaccine. Next slide. There's also recommendations for infants who are too young to receive the vaccine potentially here, and they can receive a monoclonal antibody. This is preventative medication and not a vaccine. It's 90% effective against severe RSV, and all infants less than 8 months of age, unless mother's vaccinated. Again, if your mother's vaccinated, then this passed on to the infant and it will last several months. High risk children also 8 to 19 months recommended in a time when RSV is very prevalent. Again, it's effective, but it lasts in your system for about 5 months. So October to March is the ideal time to get this if you're too young to actually receive the RSV vaccine itself. Next slide. Clinical recommendations for COVID-19 vaccinations. The CDC adopted new recommendations recently, emphasizing shared clinical decision-making rather than universal recommendations. The updated vaccine is to target the Omicron subvariants JN.1 and LP.8.1. It is 30 to 60% protected against urgent care and hospitalizations. Who should get this? Adults 65 and over. The vaccination is recommended after consultation with a healthcare provider. So this can be, at this point, a physician, a nurse practitioner, a physician assistant, and at this point, pharmacy in some states are considered healthcare providers, and I have a good relationship with our local pharmacy teams here, and they give really good advice on vaccinations and combinations there. But this varies from state to state, I believe, at this time still. And who should get it? Age 6 months to 64 years may receive the COVID-19 vaccine based on provider discussion of risks and benefits. And when is it? Its access varies due to state and federal differences, but now, if it's available to you in your state, I would recommend that you get the vaccine. It does help against COVID. And again, speaking as a hospital physician, I've seen COVID-19 illness again this late summer, early fall, enough to make me realize that this is a situation that is still prevalent, even if you haven't seen COVID as much as we had, thankfully, in previous years. It is still around, and if you have any of the comorbidities, they're definitely worth getting the updated vaccine at this time, and it will avoid having to see a doctor like me in the hospital. Next slide. So policies shaping access to care. This again is updated as of today. Next slide. So where does our guidance come from? So here's where we have our United States health system. The Food and Drug Administration, FDA, approves vaccines. They are usually developed by the ACIP. ACIP is the Advisory Committee on Immunization Practices. There's been some recent changes in the AICP makeup. And so ACIP have been very good over the years in looking at which vaccines to recommend, the risks and benefits. And they develop the recommendations, which then the CDC takes and sets schedules based on the ACIP recommendations. So the CDC, again, is the Center for Disease Control and Prevention, and they set the schedules. The states then implement policies. Sometimes depending on the state itself and local recommendations, each state has their Surgeon General, and policies differ based on the Congress, on different states. And so these can be applied differently in different states. Some make it easy to get the vaccines, some make it mandatory or at least opportunities there so that there's no financial disincentive. And then there are pharmacies. They administer and deliver. And again, there's variability in pharmacies from state to state. The recommendations also come from the organizations that I use the most. So like I said, a member of the AAFP, the American Academy of Family Physicians, and they put out bulletins and memos periodically to update on the recommendations based on the best science. And as family physicians across the nation, we follow the guidelines of the AAFP. We also look to the AAP, the American Academy of Pediatricians, for guidelines on children and vaccination schedules there. So for right now, my recommendation is to look for the AFP and AP guidelines because they are still based on the most solid science that I can recommend at this time. Also, the ACOG, which I think we'll talk about a little bit, the American College of Obstetrics and Gynecology. ACOG gives us information on pregnant people and what we can do for vaccinations for them. Next slide. So the COVID-19 landscape. So we have been moving away from the broad message of vaccination for everyone approach, and now we're moving towards individual decision after seeking medical advice to determine risk. This was under the new administration that came into power just this year. And we're looking at this closely to see, if this is going to be at the most effective and beneficial for our patients, but that is to be determined. Previously, the recommendations were the COVID-19 vaccine was open to everyone 6 months or older. Now, high-risk conditions are very broad. So pregnancy, diabetes, obesity, cancer, disabilities, mental health conditions, and others. So in total, it still covers most people. So as a result, right now, I think we have about 75% of US adults qualify. But again, there's confusion regarding what is the best approach to the mutual agreed upon broad spectrum of recommendations. Again, because this can vary from state to state. And so we're watching this very closely to see which states are going to be doing better. And that data is still out as of this time. Next slide. So, season of confusion. So, FDA versus medical societies. The AAP, again, the American Academy of Pediatrics, say all kids under age 2 should get the vaccine. The ACOG recommends all pregnant women get the vaccine. American College of Physicians and the Infectious Disease Society of America, IDSA, recommend for many adults. The new shared decision framework was designed to encourage provider-patient conversations, but it also has introduced some confusion as to who in each state is skilled enough to have this conversation and where does opinion come in and where does the good science come in. So there's some mixed messaging. Providers versus the FDA label sometimes are not consistent. So as a result, families already marginalized in communities and providers and pharmacists are caught in the middle. So there is a lot of discussion to be had. And again, I'm hoping that the changes that have been made will benefit Americans all across the nation. But I'm going to be watching closely as this season unfolds as to which states do a really good job and which do not, which could be a model for 2026 and moving forward. Next slide. So state variations I mentioned, many states have taken steps to maintain or expand access. So 26 of our 50 states have announced broader access policies. 13 states now require state-regulated health insurers to cover COVID-19 vaccines at no cost. Again, not every state does this, but 13 of them do. Pharmacist authority varies. In some states, pharmacists can vaccinate children as young as 3. In others, access is more limited. Again, the licensing of pharmacists and physicians go uh, to the state. And so the state will give us licenses, and we have to follow what the state recommends in order to keep our licenses. So in some places, pharmacists may hesitate if they have no clear guidance as to whether they can vaccinate, which age group, et cetera. So if we have any pharmacists on this call, I'd love to hear from you in your state, what the situation is. We'll have some time for questions near the end here. So other states have not yet clarified coverage or access, creating uncertainty for uninsured or underinsured populations. And some people don't know going to get a vaccine whether they're going to have this covered by the insurance, or if they're not insured, what it's going to cost them. And sometimes that cost can be prohibitive. Next slide. So barriers to access. Again, the CDC recommendation to consult a clinician, although it does not specify which. So this can still cause a barrier. COVID vaccines without insurance cost between $140 and $200, depending on brand and location, and not including a pharmacy administration fee. So this price source was from a Walmart pharmacy, Walgreens, and CVS Minute Clinic. Insurance coverage, uncertain for some groups. Again, some of those states that we just talked about does guarantee that your insurance will cover it, but that's not, again, in every state. 90% of COVID vaccines are given at pharmacies. Now, this can be a big disruption between what pharmacists need to do and the talks they need to have, and also if it's going to be your office, your family physician giving this to you, or at this point, many family physicians just say go to the pharmacy to get it. So right now, a large percentage of this is given at pharmacies, and I'd love to have this be clearly guiding our pharmacies in all 50 states, and I hope that that will happen. Right now, we're also government shutdown. We put this in here a couple of days ago, and we were wondering if we could take it out, but we can't take this line item out yet because the government shutdown still continues. So this limits the support from government agencies during this time to get any kind of answers. So the government is still shut down, and we're still waiting. Next slide. Existing barriers also cost, usually out of pocket for those without insurance. Again, $140 to $200 plus a administration fee is prohibitive for many of our clients at MCN. Logistical. So clinics and pharmacy hours and overall availability of doses, even for those eligible. So I know in my town, a couple of pharmacies have run out, and other ones still have it. Some have flu shots, but not COVID shots. Some have the RSV and not the other ones. So it sometimes takes a while to figure out where to go to have the shots that are recommended that we were talking about here. Ideally, you'd have, once stop shopping at the pharmacy, but that's not always the case. So there's a heightened climate of fear also. People are um, they're getting monitored and sometimes being detained by ICE at various places, including, unfortunately, some health centers that have been reported to us. And so people don't want to go out for fear of not getting vaccinated and also not being able to return home to their families that afternoon. So people are keeping a low profile in many areas, which will potentially impact the percentage of people getting vaccinated this fall. And there's a lack of up-to-date and accurate communication. This is why we have this webinar today, to try to give you the most up-to-date and accurate information, because we don't want to deepen confusion and health inequity. We want to make sure that everybody gets the right information as up-to-date as possible to provide, our clients, our patients, the best care possible. Next slide. So what has changed? Well, first of all, science hasn't changed. I was a hospital physician for many years now. In the last 5 years, I'd say since March of 2020, I have seen over 5,000 COVID cases that were sick enough that we need to hospitalize them and often put them in the ICU. And it was a very difficult time. Even after the vaccination program became available, many in our community did not get vaccinated. They choose not to get vaccinated. So this has been pretty terrible. But what we have learned over the 5 years is that, the science is evolving, but it really hasn't changed as to should we get vaccinated? The answer is still yes. COVID vaccines remain safe and effective against death and hospitalization. And I can see that now with death rates way down from where we've been in the last 4 or 5 years. Our environment has changed. There's a higher population immunity compared to early pandemics. And this immunity lasts a shorter time, but there are more people who are immune. And so the general likelihood of catching this is a little bit less now than it was before. And also, there are variants of COVID right now that seem to be less lethal. However, if you're somebody that has one of those comorbidities that we just described, it still can be very lethal. Our hospitals are thankfully not overwhelmed like before. Um, Community perception has also changed. I think there's some community ideas that they can be more cavalier, that this really is not a problem anymore, that COVID is over. And I understand the wish for COVID to be over. I mean, I would wish that COVID to be over as well, but it's not. It's still around, and it can change its outer surface proteins, and it can change its variants and become, much more lethal once again. So we have to keep an eye out and vaccinate as much as possible to keep that at bay. And there's also policy that is shifting. Again, I think many politicians do not want to go back to doing the things that we used to do, which is, washing hands, masks, and keeping a distance when COVID becomes more prevalent in your community. And so if you see this happening, we're going to go over some things to still do, still things that are not old-fashioned. They're still worth doing, even now. Rollout and delivery is also a challenge because it's inconsistent and unclear. Some states will get more, and some states will not get the same, and the information may vary from state to state. And as a result, I think less than 25% of adults got last year's booster. And that is very worrisome because once it spreads around, it can still cause enough disease that you are not able to do your work, do your job. You have to come into the hospital where you may also pick up something else because you may get COVID, but your neighbor in the other bed has influenza and somebody else has RSV and somebody has metapneumovirus. So you can collect a whole bunch of things just by getting, one illness, one viral illness. And even though the hospitals try to keep patients safe and doctors wash their hands, nurses wash their hands, once you're in the hospital, you're subject to whatever else is in the hospital at that time. And so fall and winter can be very challenging. If you get one viral illness, you may also get another one. And I've seen that happen even with the best hospital safety and sanitary policies. Next slide. So, what to expect? So, there's lots of questions about eligibility and cost. And hopefully, your family physician, your pharmacist will be up to date as to what those are in your particular state. Then we need to clarify that vaccines are still available in most states without a prescription. I wish I could tell you every state, but that is also changing, hopefully for the better as we get into the fall season. And we have to reinforce that shared decision making does not mean restricted access. It just means the decision has to come from both the patient and the clinician and agreeing upon and being exposed to all the different thought processes and risks and benefits of the vaccine. Next slide. So, what still works? Well, at the hospital, always, and in the outpatient setting, always, hand washing, social distancing, good ventilation, masking, getting vaccinated for other respiratory infections in addition. Um, these methods work best in combination with the vaccines. So these prevention methods are not just for COVID-19. They're also for influenza. They're also for RSV. They're also for metapneumovirus, parainfluenza, rhinovirus, enterovirus. All of these, the things that we realized, even though the difficult years of 2021, 22, we had a lot of draconian measures to prevent COVID from spreading. And we also realized during those times that influenza A was not spreading as much because no matter which virus you were trying to protect against, these methods worked for protecting against many different viruses. And so we had a unusually low, thankfully low, season for a couple of years of influenza as well as COVID while we were trying to protect our patients and ourselves against COVID by doing these things. So we just know that these methods that we're talking about here will work for very many different viruses. So please do them and still work. Next slide. So strengthening the uptake. The important thing when you're doing shared decision making is to provide clear, consistent staff messaging. Clarity is the antidote to confusion. And we try here at MCN to give you the best up-to-date information. We try to provide many of these webinars in English and Spanish because we wanted to provide you with a clear, consistent staff messaging so that you can then take it to your own staff and provide the best information possible. Use community health workers as trusted messengers. This is really important. We found this in all sorts of different situations that the community health workers, and if you're out there today too, I mean, thank you so much for all your work and everybody actually listening here. I know the hard work that you are all doing. And it's central to trust building and shared messaging. Because a lot of times you don't know who's giving you the message from some advertisement on TV. Maybe you just don't know, but your people that you trust, your community health workers, your health workers in your local communities are the people you should trust. Monitoring state and federal updates and share simply. So we try to make this as simple as possible. That we do want to do our part in MCN to monitor the state and federal updates as they come out, and then try to bring them to you, and then try to answer questions as best as possible. Tailor education to culturally and linguistically appropriate measures. I find that I can talk a lot in fancy medical language as a doctor to my patients, but if they don't understand, it's no good to me. It's a waste of my time. It's a waste of their time. And it's really inappropriate. So using cultural and linguistically appropriate language so that people can understand. We often do a teach back method, and I teach my medical residents and medical students a teach back method where the patient can tell me exactly what they think I told them using their own words. And then I can understand that they actually get what I'm saying. But just throwing it out there and using fancy words can make a physician look smart, but actually it's quite not useful. It's detrimental. And remember, updated vaccines significantly reduce severe illness. And I can't emphasize that enough as a doctor who works in the hospital again. I've seen this over the last 5 or 6 years that the people who come in are often the ones who are either not vaccinated or under-vaccinated, or they have comorbidities where they should have been vaccinated and they just didn't know that they should be because they had these comorbidities. So this is really vital to strengthen the uptake of vaccines. Again, all three of the vaccines we just talked about. Next slide. Okay, I'm going to turn it over to my partner here, Esther. It's all you now, and we can at this point try to answer a few questions. I know and hope I didn't go too long here, but I would be
Um,
happy to answer questions. And Renee is on also. She's great at giving us the sources of information. So if I say something and I don't have the backup here, Esther and Renee would be my partners here to pop it up in the chat if there's something that is missing or
so
needs a source.
there are no questions in the chat at this moment, Laz, and I just want to remind you, if you guys have questions, please stick them in the chat. You can also raise your hand, and I can unmute you. And I know that there's several of you here that are bilingual, so si
Yeah.
tienen preguntas, por favor, pónganlas en el chat y nosotros vamos a responder a sus preguntas. Okay, Esther, take it away. Thanks, everyone.
Yeah, no, thank you. Yeah, we wanted to leave just a little bit of time right before we got into the resources to really share or expand on any of the information that Dr. Laz has shared. But yeah, let's take a little bit of time to look over some of the resources that we have. So before I get started, I just wanted to mention that the resources that I am sharing with you today, for the most part, they are all available on our website. They are all available in English and in Spanish. They are all available for free, for download, and for you to print on your own. So I just want to highlight those important pieces. Unfortunately, we're not able to print them on our end, but they are available for you to print on your end. Okay, so let's go ahead and get started. So one of our first pieces that we have has actually been updated very recently. This includes the most recent CDC recommendations for COVID-19. So just as Dr. Laszlo Medeiros has mentioned about the shared clinical guidance, who can get the COVID-19 vaccine? This is a very quick fact sheet, like I mentioned, available in English and Spanish, which can be printed out in a regular document 8 by 11. Beautiful colors. We work with an illustrator here who is able to make these wonderful illustrations, which are culturally relevant, culturally appropriate. And it does include some information down here for the COVID-19, CDC COVID-19 webpage. And there is some space at the bottom for you to edit and include your own logo as well. And as Martha mentioned earlier, you are going to be receiving a PDF of the presentation here today, which does include the live links to all of these web pages, so you can easily access them here. But if you want to access them right now, you can go to our website, www.migrantclinician.org, and then go to our respiratory page, and they should all be available there. The next one is a really, really cool, also recently updated comic book that we have. So this one, we have it as a virtual and interactive comic book on our website. We have a really cool embedded feature which allows you to actually flip through the comic book right from the website. You can also print, download it for yourself as well. This comic book, it tells the story of farm workers who are actually picking tomatoes, and then they're discussing, who should get vaccinated. And these are adult males who are talking about not just COVID-19, but also all different, types of vaccines from hepatitis B to Tdap and all sorts of different types of vaccine. And we also weave in heat stress messaging and how to prevent heat stress or heat stroke on the job. So these are really cool. Some of my favorite comic books that we have available for you to access. And another comic book, or flip chart, if you will, that we have available, which actually comes with an accompanying facilitator's guide, is our COVID-19 and our community flip chart. So this flip chart is, again, available in English and Spanish. This one, I would say, is a little bit more on the basic language side. So it's a little bit heavier on illustration. And the way that you utilize it is it would be propped up so that the image is facing the patient or community member, and then the facilitator or the CHW would read the facilitator's guide and explain what is going on in the images. It explains all of the basic information. It explains myths about COVID-19. We do talk about all sorts of different types of vaccines, not just COVID, like we talk about flu in here. And it's a really, really fun, interactive way to engage all sorts of community members from young to old, and everyone in between. All right, and here's another resource, and this one is more specific to our community-based organizations and our community health workers. So this is a community-based communications campaign manual. So this is everything about how to design your own community-based communications campaign. So within this communications campaign manual, we have all of the information you need about what does it mean to create your own communications campaign? What is the role of a CHW in the community? It was designed with COVID-19 in mind, but it can be adapted to really focus on any emerging issue, any infectious disease, really any health initiative that you want to communicate about with your community. And it also includes some really fun links in there and also editable tools for you to adapt and use within your own community. So this is really a treasure trove of many different things that you can use on your own. And I also wanted to mention, I know there's a few people on this call or on this webinar who might have already attended, but we do have our recordings available now for this session, which was already done in Spanish. It was completed last Wednesday. It is available on our site. So if you wanted to share with other folks who might be interested in the same information, it can be accessed here. Or you can access other webinars which have more information outside of vaccination. We have some great webinars that are upcoming or previous webinars which we have archived in our webinars archive. And then we also were able to also complete a webinar on building trust to equip CHWs with similar information about fall vaccines. So we expanded a little bit more on misinformation, disinformation, and then also building trust or rebuilding trust and during these times of confusion. And I also want to highlight a very fun and really cool opportunity that we have right now that we are now on Substack. So our MCN blog, if you have already subscribed to our blog, you might have noticed that we have moved to a new platform called Substack. It's an interactive platform that kind of reads the same as a blog, but a really cool function of it is that you can comment, you can like, you can repost blogs that you like. And then we are also, as of recently, now promoting that it is available in Spanish. And then lastly, we also would like to share that if MCN has helped you in your work, if you want to share how we have helped you, any stories that you might have about us and our work, and really any comment, we would love to maintain our status on Great Nonprofits. You can leave us a review. The link is here. We have a current 5-star rating on Great Nonprofits as of 2024. And we would like to keep it. We love to hear from you. And yeah, you can also always connect with us on social media. We're available on Blue Sky, on Facebook, LinkedIn, and on Instagram. Our handles are here at the bottom. And our website, as I mentioned, is www.migrantclinician.org, where you can find our latest resources, any updates from the field. As I mentioned, that Substack is available, so you can add yourself to the Substack there for English and Spanish. And then you can also register for any upcoming webinars, find our archived webinars, and also all of the resources that I just mentioned are available on the site. Okay, I think we now might have some questions, do we?
Yes, we do. Thank you so much
We
for that,
do.
Esther.
Okay.
Laz, go
Yeah, so
ahead. Yeah, go ahead.
I saw a question, which is a very good question. The question was, how long can a client wait to have an influenza vaccine after chemo session, or should they obtain a letter that states the client is cleared to have an influenza vaccine? That's a great question. Some of this depends on what chemotherapy they're getting, what kind of illness they have. If this is some kind of cancer and they're immunocompromised. There's a thing called neutropenia, where a lot of lines of your immune system have been diminished. On the one hand, it's really important that people who have some immunocompromise get the vaccine. But if it's right after a chemotherapy treatment, I would talk to your oncologist, the cancer doctor, to see, what is being treated. So some people have lung cancer and they have like part of their lung removed, and they're also, getting chemotherapy for lung cancer and then radiation on top of that. So sometimes their white cells drop, sometimes all their lines drop, and that would make it more challenging, but also imperative that they get it at some point in the flu season. So I think the timing of that is really dependent on the individual patient, and I think the oncologist and the family physician working together on that could help like fine tune that. I know that a lot of times I have patients who have come from chemotherapy and they're hospitalized because they got sick. And so now, we're worried that they also have RSV, and we can't give them the influenza vaccine at that time. So the answer to that question is a very good question, but the answer is kind of more individualized as to which cancer, which chemotherapy, what is their complete blood count looking at this moment, and when is their next chemotherapy scheduled. And as a family physician, you can work with the oncologist to kind of space that out a little bit, or make it so that they get the best benefit, and get the vaccine because it's important as immunocompromised patient. So I'm not sure if that I can be any more clear than that, but it is a great question to work on with your primary care doctor, your primary care team who knows you, and your oncologist.
There's also another question in the chat, and I think maybe Renee, you might be the best person to answer. Hugo is asking, how can we help marginalized families with no insurance and no financial resources to cover the cost of the flu or COVID vaccine?
Oh, that's also a interesting question and a complicated one. In part, that will depend on where you live and what is available. For flu, at least where I live, someone should be able to go to the health department who is not interested in people's status or things like that. And it may or may not be able to get COVID. So for example, cannot get COVID in my state without paying for it, but my children can. And so I think that this is going to vary from one place to another, but health departments are a great resource, and you can try also many of your community health centers will be operating on a sliding scale, depending on people's. And again, I know many people are not comfortable going out to some of these places. But I think that's the very hard part of making that decision of trying to prevent getting illnesses while still being safe. So really just trying to maybe call first, ask what's available, see if there's some time slots that are viable. But those, there's no way of knowing for sure what's happening in your community. Maybe you have, I know here also there's some different places where I can be on the lookout if someone knows, for example, that there are federal folks lingering around. So try checking those ahead of time too, right? Complicated advice to give, and I'm sorry that that is my answer this year.
Yeah, I can add a little bit there. And also, I work with the state health department in Pennsylvania for TB control. And I know sometimes we have vaccines, and sometimes we have COVID vaccines, sometimes we have influenza vaccines. And when they run out, then we don't have them for a while. And so it's really hard. It adds more complexity because sometimes we have something and then we gave all away our whole supply, and we're happy that we could help our local community, but then we may not get the next supply for a while. So it's not always consistent in terms of what we have and how long we have it, and before we get the next supply either. So it is quite challenging. So we try to when we get a new supply, we try to keep a list of people who wanted it and then give it out to them. But again, it does vary state by state, which is what we just talked about, the confusing aspects of trying to get advice specifics in a time when all 50 states are doing kind of different things for the different vaccines as well.
Thank you, Lance. Does anyone else have any questions? If you have a question, just go ahead and raise your hand and we can I could take you off mute and you can ask your question directly. In the meantime, Esther, can we put up the evaluation link or QR code?
So I just have one other comment since we have a little time here, and that all the vaccines that we just talked about and other vaccines, including the MMR vaccine and other ones that we give out, we have not, in the scientific community, we have not yet found anything. I'm just going to say, not even use the word yet. We have not found over many, many years now that anything has been linked like this to autism. So I know there's a lot of confusion out there about vaccines and autism right now, but all the studies, and these studies have been done for years because all of us clinicians, we're taught to do no harm. So we really want to get the best science to make sure that we don't do any harm. And I have never seen in my 30 years yet any kind of link in any study that does tell us that autism and vaccinations are linked. They're not, and so I know that thought is out there right now, but it is not something that I'm not concerned about. I vaccinated all my kids, my cousins, my nieces, everybody, whole family. If I had any concerns that I'd be causing harm, I would not have done any of that. So I just want to just reassure the community here. I know we're not talking about MMR vaccines here specifically, but I want to include this in that, shared decision making. I think that is something that some patients may ask about, and so I want to reassure you. You can hear from a physician here that's been working in family medicine and hospital medicine now for 30 years that we do not have that link. So no autism.
Thank you for that last.
You're welcome.
And while we're waiting for some questions to come in, I just want to remind you all that this session is being reviewed by the American Academy of Family Physicians for continuing medical education. So if you want to receive a certificate of continuing medical education, you will need to submit the post-session evaluation, which the QR code is on the screen right now. And the same thing goes if you want to receive a certificate of successful completion, please remember to submit your evaluation. I don't see any more questions. Again, if you have a question, just raise your hand and I can take you off mute. I don't know if there's anything that Renee or Esther you would like to add while we wait for questions to come in, if at all.
No, just that the evaluations, as you mentioned, Martha, are super, super important for us. They help us create better and more informative webinars. We would appreciate if each one of you could take just a few minutes to complete that. And if there are any questions that you might have now or in the future, and you don't want to ask them, I know that you can ask them at a later date. Is there an email that is attached with the evaluation or in the evaluation?
There is not an email attached, but you guys can always send me your questions. And I will make sure they get to the appropriate person, whether that be Laz or Renee or someone else on MCN's team.
Yeah, Renee just put in there too that, in some parts of the United States, there are mobile clinics that go to farms and communities, smaller communities, to do vaccinations. And so that is one possibility in certain parts of the United States. So if there are no questions, I'm assuming that I was just so super clear in everything that you have no questions. That's wonderful. But I do want to thank you guys all for the hard work that you do, because this is not easy, and these times are not easy, both in terms of what's available, the science, the politics, and everything else that we have to go through. But you guys are out there. You guys are the trusted community members in your own towns and localities and health departments. So I'm really glad to be able to help, get the information out that is the best information that we have, and we will work hard at MCN to keep you updated with all the information that is coming out. Again, we try to do this in Spanish as well as in English, so the word can get out and keep you all updated. But thank you again for all your hard work.
Yes, thank you so much, everyone. And if there are no other questions, I think I'm going to go ahead and close it out. Just remember, if you guys uh, in the future have any questions, if you want to request a training or anything, MCN is here for all you that work with our mobile population. So please just reach out to us and we will do our best to accommodate you. So again, thank you so much. Thank you, Dr. Medeiros. Thank you, Esther, Renee, for your time. Thanks, everyone. And remember to keep an eye out on your inbox for my follow-up email that's going to come later today. Thank you, everyone.
Thank you.